Hi, thank you very much for having me here today. I'm really pleased to talk about the cultural alignment of key elements of person-centred care. First and foremost, I'd like to point out my wonderful colleagues who have worked with me on both aspects of the work that I'll be presenting today. So first, a small introduction to myself. I added this last minute for two reasons. One, because I want to make sure everyone's very clear that I do not announce myself as an expert. I do not believe myself to be. But also because when we're talking about person-centred care, we obviously have to talk very much about context. So I'd like to present the context of me. So I actually graduated in 2007 from an undergraduate degree in business management, where I worked then in marketing for 9 years. So this is all still relatively new for me. I disliked marketing for about 4.5 years of the 9 years, and so I retrained in health sciences, where I also worked as a nursing assistant in a hospital in the UK on an older adults ward, which gave me immediately some insight into where I wanted to go. So I moved from that to a Master's of Applied Sport and Exercise Science, where I focused on physical activity for older adults living with dementia in the community. And all of this culminated in my PhD, which was based in Switzerland as part of the Transenia program. And my second university for this, as a dual PhD-ship, was with Maastricht University. And this is where my international knowledge of person-centred care really began. So today's discussion and what I'd really like to go through today is twofold. One is my PhD project, which was tri-national ethnographic multi-case study of person-centred practices on resident quality of life in long-term residential care. We affectionately call this triangle. And the second is the cultural alignment of key elements of person-centred care, which was the title of this presentation, reflecting on 5 case studies. So to discuss person-centred care, obviously, to begin with, you need to give a brief history. And I'm not going to go all the way back to the 40s. I'm not going to go back to Kitwood, and I'm not going to bore you because, to be honest, I could spend the full 25 minutes giving you a full history of person-centred care, and we just don't have time for it. So instead, I would like to point, firstly, to McCart's-McCormack, obviously in 2006 became very big players in person-centred care, bringing together the individual and staff experiences to develop a framework which we all know very well in research. This cultural element of it and the, and the framework that's being presented looks more at hospital care, and we all know that there is a barrier of bridging person-centred care practices across care contexts. So the secondary framework, and there are many being developed that are being used, and this one you can already start to see the differences because in McCart's-McCormack they use the word patient, whereas in the AACN, the American Association of the College of Nursing, they already start to allude to the word residents. So we're really looking at the long-term care context rather than hospital care setting. Working in hospital in the UK as well, I understood that person-centred care was something that was really trained from the off. You really needed to know about it. We were trained as nursing assistants to provide person-centred care. But even in a context where person-centred care was firmly introduced as policy from the year 2000, it didn't work. Patients in the hospital were not able to express their desires, for example, for washing. If they wanted to have a bath in the evening, they weren't able to. It had to be early in the morning. And when I say early in the morning, we're talking sometimes 5 a.m. It was not the patient's choice. And this is something that does translate across to long-term care. And different cultures have brought in the aspect of person-centred care at different times. If we take China, for example, they didn't actually bring in person-centred care into their dialogue in long-term care until 2017. So if you think of how backwards the UK is at this point, and then move forward 17 years, there's a huge gap already when you look at the history of person-centred care and the culture and the context. So it brings me on to my PhD topic. My tri-national ethnography took place in Switzerland, the Netherlands, and the UK. These are 3 countries that have arguably similar experiences, similar values, similar care contexts. And so going into it, I didn't expect to see the level of differences that I did. I also went in during COVID times, which meant much bigger difference, obviously, because of the way countries dealt with situations there. But looking specifically at person-centered care, the difficulty was that in practice, each place is trying to cater for essentially a communal setting, which is very, very challenging in a long-term care community when you're also trying to take into account individual needs. So as an example, in Switzerland and the UK, in meal times, there were choices given, but it was really, residents said to us, you know, if you don't like this choice or you don't like that choice, there's nothing else. Whereas in the Netherlands, the choice really began from the point of ordering ingredients, putting the meals together. So there was you could already start to see some differences. We used ethnography during this to fully understand and fully immerse ourselves in each environment, but also organised local research assistants to come into play to make sure all of the nuances, all of the colloquialisms were fully understood in each of the cultures and the contexts. So person-centered care is a global context. I've already touched on this a bit, and we wanted to make sure that we showed, firstly, the interrelating factors between person-centered care and quality of life, which we're all aware exist. The topic of person-centered care, as you can probably already tell, because I'm jumping here, there, and everywhere, is huge. So the way we narrowed it down within the research was to look specifically at mealtimes, which came up time and time again from residents and staff, whether prompted or not. It was just a topic of discussion within the context of care homes. This information was then taken to an international symposium at the GSA in November 23, where I met an international team from Brazil and from China, and also where work had been done in sub-Saharan Africa. From my PhD, you could already see, even though through European westernized cultures, you could already see differences occurring during person-centered care. But with the international context and sitting and listening to each other's presentations, we could see the gaps really expanding. So we really needed to look at this, and we decided as a team it would be really beneficial to put this information together. So we developed a concept of a paper to come together with 5 different countries, with the aims being to evaluate the alignment of the domains of person-centered care across countries and cultures, to compare and contrast the components of person-centered care across cultures, and to assess the challenges of the assessment or the evaluation of person-centered care. And this is all based on the AACN framework that I mentioned earlier. So the included country data all came from data that was already collected. So the countries were pre-selected. It was where researchers had already been involved in the research, so that we had the data there ready to go. And the included countries were Brazil, the USA, the UK, Ghana, and Ethiopia. We sent out set questions in table format to each of the country representatives. We made sure we used contextualized information per country, because obviously, as I've mentioned, context is very, very important to understand the potential of why things might be working or not. We also looked at how the elements of the AACN framework were met or left unmet based on specific questions. And we also looked specifically at the elements of the AACN framework in the sense of, firstly, what level of independence residents had within the data, but also whether residents actually wanted independence, because this is something that, from the information presented in the international symposium, we realized wasn't actually the same across the board. So, looking briefly at the contextualized information by country, you can already see quite a lot of difference. The US, for example, the number of care homes and the outline of what the care home types are is vastly bigger than the others. In Brazil, There's actually no national standardization. So where in the UK, for example, we talk about nursing homes, we talk about care homes, they're very set concepts. We know what we mean when we say these things. In Brazil, this doesn't exist. And in Ghana, the biggest difference, there actually are no public long-term care facilities. There are private, but zero public. And in Ethiopia, there were so few that there weren't, numerically, it wasn't enough to put on a screen. The differences in policy across the board was also quite different. So, as I mentioned earlier, in the UK, it came into play very firmly in the year 2000 that it was kind of best practice, and it was really supported in training purposes. Likewise, in the US, person-centered care has been practice policy for a number of years. There is not the same national policy in Brazil, Ghana, or Ethiopia, although the discussions are starting to happen. But interestingly, what we saw in the information was, although the US and the UK very firmly said, we follow person-centered care practices, we train for person-centered care, the flexibility in how person-centered care delivered was seen to be much more present in the data from Brazil, Ghana, and Ethiopia. Now, whether that's because of the policy differences, whether there's more red tape, unclear, but it is very interesting to see that level of flexibility where it's not considered best practice. So when we look at the elements of the AACN framework, So when we go through each one individually, all of them were expressed in some way, whether directly or reading between the lines, all of them came up through the data. Supports independence was one of the higher ones, not the highest, I'll get onto that afterwards, but it was one of the higher ones. But the way it was developed across the different studies was still very, very different. And in the UK and the US, red tape, health and safety policies did actually block the level of independence given. So when we're looking at activities of daily living, meal times, being able to eat on their own, being able to look after themselves, residents in care homes, it was much less possible. Choice was an interesting one because culturally, choice is already quite a strong word. In some cultures, people are expected to be able to have choice throughout their lives. Again, in the US and the UK, it was much more similar in terms of the expectation for residents to be able to choose themselves how their healthcare was presented went on for a lot longer until they were deemed not to have capacity to be able to do so. Whereas in some of the other countries, it's actually culture that family take over choice as soon as someone becomes older or frail, and it's also to do with socioeconomic status as well. So everything does vary on culture at this point. I'm going to whiz through the rest because I think the time is running out slightly. So I'll move on to the next slide because I think what's interesting, and perhaps unsurprisingly based on the findings of my PhD thesis, where quality of life and person-centered care were very well interrelated, but the highest aspect of similarity across all of the countries was the fact that person-centered care improves quality of life. Even though this was not directly written in statements, it was really easy to read between the lines of, oh, this made someone happy, or this resident expressed feeling more positive, feeling happier, having a higher well-being. Maybe more surprisingly is the fact that the lowest similarity was in enhances dignity. Despite meaningful attempts to adhere to elements of the AACN person-centered care framework shown across all of the countries, even successful attempts had limitations. Multiple included country information demonstrated efforts to support, like I said, independence or honouring choice. But this level of decision-making was taken away in some contexts. It's really important to address cultural differences when discussing potential limitations to choice and independence within long-term care practices. For example, information from the included Ghanaian case study highlighted cultural practices of family members really taking this responsibility away. For person-centered care to be successful, in theory, looking at the past research, that can't happen. But actually, when you take into consideration the context and the culture, it needs to happen. So what we're seeing is person-centered care is definitely not, and this is something we all, I think, know anyway, but it's not a one-size-fits-all model. And it's getting increasingly more clear and increasingly more challenging to pick it up and take it and put it in another country and see what happens. We really need to adapt each time to the next step of where we're going and find ways to evaluate it within each country. So, to summarize and to conclude at the end, really, again, unsurprisingly, there's still really an overall imbalance to both the knowledge and implementation of person-centered care globally. It is important to consider and work within different cultures to facilitate a global element of person-centered care. The information presented in this paper, I need to point out, is limited to a single case study within each of the included countries. And that's across the board. That's whether it's the UK, Netherlands, Switzerland, Ghana, Ethiopia, or the US or Brazil. It's all based on one case study within each of the countries. It's therefore not really representative of all long-term care, but it does give some immediate eye-openers into what we need to look at in terms of person-centered care research, and it needs to be reflected more in future research. What we did do and what we are clear to do is contextualize our information, and that's something that's also really important so that we can understand why and where things are working or not on a national level. Information from the presented from the individual case studies here also highlights the importance of local individual context within a wider national context and what is possible or not possible in a national context. So that's all I'm going to say on it, because hopefully there are some questions open, but thank you very much for your time, and again, with thanks to my colleagues and collaborators.
Thank you very much. Stay for a moment. Szanowni Państwo, jeśli tylko ktoś z Państwa ma jakieś pytania, to oczywiście...
If you have any questions, feel free to use the microphones. And it's the right time to do so. If not, I have a question, really.
Szanowni Państwo, taka rzecz, która mnie...
I mean, listening to the presentation, I noticed one thing. There was this theme that the issue of choice we associate with person-centered care is conditioned on the conditions in the given country and the cultural context. But if you look at the model and these 6 factors, actually 3 of them were very much based on choice. So if not choice itself, if dignity that was marked as a factor that was lowest ranked, what else?
Was a factor that was pretty dependent on the country and on the context of the culture itself. And when I was looking at the model that you were presenting, I think the 3 of the factors could be broadly attributed to choice. We had empowerment, we had independence, we had choice itself. Then you said that the dignity itself was not always highly valued, and it was one of the lower valued factors. Then what else is left? And what are the alternatives? When we are talking about person-centered care, in general, we mostly see it through our European lens. And then what were the takeaways for how different this person-centered care can be if the lens is different? So if you could expand on that for a bit.
That is a very, very interesting question. So I think one thing that we've discussed amongst the team, and something that needs to be considered, it's not taking out words like choice, but it's defining what choice means. And that's the difficulty, because what choice means to us in a European context is completely different. So in the case studies in Ghana, they believe they have as much choice as they need to have. They actually don't want any more choice in those care practices. Whereas to us, that seems crazy, and it seems, you're looking at it going, well, how can we enable more choice? And with dignity being lower, that one was more clear in terms of the case study showing residents being left kind of exposed in corridors, and so that was a very much clearer aspect where it was lacking. But yeah, when you take out choice, or when you define it in a different way, yeah, I don't know, you can't replace it because it's necessary. But I just think it needs to just have levels of definition based on the person.
Like enough choice.
Yeah, exactly.
Yeah. Thank you so much for